Hello and welcome to the National HIV Curriculum Lecture Series. My name is Brian Wood. This lecture will focus on the combination tablet Bictegravir-Tenofovir alafenamide-Emtricitabine. To begin, these are the components of the combination tablet. Bictegravir is an integrase strand transfer inhibitor, or INSTI, and tenofovir alafenamide and emtricitabine are nucleoside reverse transcriptase inhibitors, or NRTIs. The dosage is 1 tablet once daily, and it can be taken with or without food. To examine the mechanism of the components of this combination tablet, first let's look at bictegravir. As a reminder, following reverse transcription, which produces double-stranded HIV DNA, integration of this HIV DNA into the host cell DNA is a multi-step process. Bictegravir, like other currently available integrase inhibitors, binds to the integrase enzyme and blocks a specific step in this process called strand transfer. This is the actual transfer or splicing of HIV DNA into the host DNA. For this reason, integrase inhibitors are often referred to as integrase strand transfer inhibitors, or INSTIs. Tenofovir alafenamide and emtricitabine, on the other hand, are NRTIs. They block HIV reverse transcription. They do this because they resemble human nucleosides in their structure, so when incorporated into the elongating chain of DNA, no further nucleosides or nucleotides can be added. For this reason, they are referred to as chain terminators. Here, I'd like to summarize several important clinical reminders about this combination tablet. First, it should not be offered to individuals with creatinine clearance below 30. This is primarily due to the tenofovir alafenamide, or TAF. Second, it is not a recommended agent or regimen to initiate during pregnancy, primarily because there is not yet sufficient safety data for bictegravir during pregnancy or breastfeeding. Next, it is a well-tolerated tablet generally, though some nonspecific side effects or GI intolerability can occur. Now, this combination tablet has fewer drug-drug interactions certainly than some other antiretroviral combinations, such as those with pharmacokinetic boosters. But as you can see, there is a short list of medications that are absolutely contraindicated and should not be combined with this tablet. In addition, it's important to note that bictegravir does raise metformin levels a small amount, though not as much as dolutegravir. And in general, we don't dose-reduce metformin when combined with bictegravir, while we do when combined with dolutegravir. In addition, bictegravir does interact with compounds that contain cations such as calcium or iron, so it's always important to review a patient's full medication list, including over-the-counter supplements, laxatives, or antacids that may include these or other polyvalent cations, and there are explicit recommendations for how bictegravir, TAF, emtricitabine can be co-administered with such cation-containing compounds safely. Another important clinical point about bictegravir is that it inhibits secretion of creatinine from the bloodstream into the proximal tubules of the kidneys. The effect is that the serum creatinine level rises a small amount, often in the range of 10% or so, in the first few weeks after starting the medication. This is a benign effect. It is expected. It occurs with bictegravir as well as dolutegravir and several other antiretroviral medications. What we often see is a small rise in serum creatinine after initiating the medication. Then the serum creatinine rise plateaus after the first 4 to 8 weeks of taking it, and in essence, a person has a new baseline serum creatinine. Now let's turn to reviewing a few clinical trials of bictegravir, TAF, emtricitabine. At times, I will use abbreviations and will refer to this as bictegravir TAF FTC or BicTAF FTC. We won't review all of the clinical trial data, but we will look at a few important studies. First, let's examine 2 trials of bictegravir TAF FTC as initial antiretroviral therapy. In this study, investigators enrolled adults with HIV who were antiretroviral naive, had viral loads above 500 copies, estimated GFR above 50. All were negative for HLA-B5701 due to possible randomization to abacavir, and all were negative for hepatitis B. That again is due to possible randomization to a regimen that has abacavir, lamivudine, and lacks tenofovir. This would not be an adequate treatment regimen for hepatitis B co-infection. Individuals who enrolled were randomized 1-to-1 to either receive bictegravir-TAF-FTC or dolutegravir-abacavir 3TC, which is lamivudine, as their first antiretroviral regimen. After 48 weeks, you can see that both regimens demonstrated high virologic efficacy. The virologic response rates were not statistically different between the two options, and importantly, no treatment-emergent resistance occurred with either study drug. In addition, both study drugs were relatively well tolerated, though I would highlight that more GI side effects like nausea were reported with the dolutegravir-abacavir 3TC combination. This is common. I think the abacavir component can be difficult to tolerate at times and may cause more GI and other nonspecific side effects or symptoms than the TAF-FTC NRTI combination. You can also see in the bottom row the mild change in estimated GFR, which again is due to expected effects on serum creatinine secretion, and again is not thought to represent a true decline in renal function or a change in true creatinine clearance. Again, this is predicted and benign and occurs with both bictegravir and dolutegravir. In a related trial, researchers compared efficacy and safety of bictegravir-TAF-FTC versus dolutegravir plus TAF-FTC, again as initial ART. The inclusion criteria were similar and are listed on the left. The main difference is that participants in this trial did not require HLA-B5701 testing, and hepatitis B was not an exclusion. You can see the randomization to either option for first-line therapy. Again, after 48 weeks, you can see the virologic efficacy results. The viral suppression rates were quite high and were statistically similar. Again, I would emphasize that no participant discontinued either study drug due to lack of virologic efficacy, and no treatment-emergent resistance to either study drug occurred. What this indicates is that these medications work incredibly well at suppressing HIV, and the development of new resistance to any component of these study drugs is quite rare. We will talk about this in more detail, but this is one of the reasons that bictegravir and dolutegravir are often described as having a relatively high barrier to resistance. Again, both study drug combinations were relatively well tolerated with low rates of side effects, and in the bottom row you can see the predicted and benign change in estimated GFR. Again, this tends to occur in the first 4 to 8 weeks after starting bictegravir or dolutegravir. Now let's turn to two clinical trials that evaluated a switch from other antiretroviral therapy to bictegravir-TAF-FTC. First, in this study, investigators enrolled adults who had suppressed HIV RNA levels or viral loads while taking a boosted protease inhibitor plus 2 NRTIs. You can see other inclusion criteria, and I would note that individuals were excluded if they had any prior history of virologic failure or any confirmed or suspected integrase resistance. Participants were randomized to either switch their ART to bictegravir-TAF-FTC or to continue their baseline regimen of the boosted PI plus 2 NRTIs. Here is the breakdown of NRTIs that participants were taking at baseline. As you can see, the majority were taking tenofovir DF-Emtricitabine, that is also sometimes abbreviated TDF-FTC, and you can see the distribution of participants taking boosted darunavir or boosted atazanavir. Those proportions were relatively even. Here is the primary outcome, which demonstrated that switching to bictegravir-TAF-FTC was as effective as continuing a boosted PI plus 2 NRTIs. Both options demonstrated very robust virologic suppression rates. Not surprisingly, you can see here that lipid parameters were somewhat worse, with the boosted PI regimen, and we do generally consider the non-boosted integrase inhibitors like bictegravir to be easier on lipids and better for lipids than the boosted PIs. But let's examine important findings from one additional switch trial. This study, called BRAAVE2020, has several important features and findings. One very important feature is that the study enrolled adults in the US who self-described as Black, African American, or mixed race that includes Black. In addition, for this trial, it was okay for participants to enroll if they had certain NRTI mutations, such as the common M184V or M184I mutation. Participants could also have up to 3 thymidine analog mutations, or TAMs. Participants were randomized to either continue their baseline ART regimen or switch to Bictegravir-TAF-FTC. Here are the primary outcome results, which importantly demonstrate that a switch to Bictegravir-TAF-FTC maintained virologic suppression at a very high rate, and a rate that was not inferior to continuation of baseline ART. And this finding held true whether or not participants had the baseline NRTI resistance mutations that were allowed, including M184V or I, or up to 3 TAMs. So this is one of the reasons that we have become more comfortable prescribing Bictegravir-TAF-FTC in the setting of an M184V or I mutation, or sometimes in the setting of other limited amounts of NRTI resistance. And there are other studies in the literature that also support this finding and this practice. Let's focus a bit more on what happens with virologic failure while a person is taking Bictegravir-TAF-FTC. I think it's worth noting that if a person is taking this regimen and missing doses, they certainly may develop virologic rebound. But the key point here is that the development of new resistance to the components of the regimen remains rare even when virologic rebound happens. It's been described that resistance to bictegravir can occur, but clinically we just don't see it happen very often. When new resistance to bictegravir does occur, the most common integrase mutation to develop is R263K, which is an integrase mutation that confers low to intermediate resistance to all the currently available integrase inhibitors. Now, if a person develops virologic failure while taking Bictegravir-TAF-FTC, they may also develop M184V or I, the NRTI resistance mutation, but again, that is pretty rare even in the setting of missed doses and even in the setting of virologic failure. What happens more commonly when a person misses doses of Bictegravir-TAF-FTC is the viral load goes up, you check a genotype resistance assay, and there is no new resistance, meaning the regimen remains active and usually can be restarted with close monitoring of the viral load. One important clinical reminder, though, is in this situation, if you are checking for resistance for a person who is missing doses of a Bictegravir combination, it is necessary to check for resistance in both reverse transcriptase as well as in integrase, and in some labs or some clinics, this may require a separate order to be sure that an integrase resistance assay is performed. Another clinical consideration that has come to light in recent years is the differential weight effects when comparing different antiretroviral classes or medications. What has been observed now in a number of studies is that after ART initiation or after a switch of ART, individuals who take bictegravir or also dolutegravir may gain more weight than individuals who take alternate options such as NRTIs or boosted PIs. The weight gain that occurs with bictegravir or dolutegravir may also be more pronounced if the bictegravir or dolutegravir is combined with TAF as opposed to other NRTIs. Now, this is certainly an important clinical consideration, and we do counsel patients about this potential. I think that this clinical finding must be balanced with the overall high virologic efficacy of bictegravir and dolutegravir, as well as the high barrier to resistance and the otherwise good tolerability, as we have discussed. Now, not everyone gains an unhealthy amount of weight on these agents, but certainly some individuals do. For many, the weight gain plateaus after 6 to 12 months, but not for all, and some individuals may gain substantial weight and may develop metabolic complications. Now, certainly, again, we counsel patients about this. We encourage diet and exercise and visits with the nutritionist. And if substantial weight gain has occurred, and especially if complications of that weight gain have occurred, we engage in shared decision-making and help counsel the person about alternate options for antiretroviral therapy and help individualize the decision for the optimal regimen. Here is an example of findings that demonstrate the differential weight gain observed among various ARV drugs or classes. These results are from a pooled analysis of ART initiation trials, though, as I mentioned, results of ART switch studies have found similar observations. So, to summarize, Bictegravir-TAF-FTC is an oral, once-daily single-tablet regimen. It is used commonly as initial ART or as ART for treatment-naive individuals. It is also frequently used as a switch option or an option for persons taking other regimens who would benefit from a switch or simplification of therapy and who have no integrase resistance and either no NRTI resistance or sometimes limited NRTI resistance. The combination is occasionally used with other ARVs to craft a salvage regimen for persons who have developed resistance, but that decision really depends on which specific resistance mutations are present. A reminder that bictegravir artificially raises serum creatinine in a small amount. It may lead to more weight gain than non-INSTI options, and it does have a few drug-drug interactions that should always be considered, including with some over-the-counter meds like cation-containing compounds. Thank you.
The production of this National HIV Curriculum Mini-Lecture was supported by funding from the Health Resources and Services Administration.